Thank you so much for attending today's webinar. It is on advocating for a healthy Texas. So it's going to be an overview of the state of women's healthcare in Texas at the moment. The presenter today is Laurie Glaze, who is the executive director of One Voice Texas. And if you have any questions, go ahead and save them till the end. I'll unmute the phone if you're on the phone, or you can type them into the chat box, whichever you'd like. So I'm going to hand it over to Laurie, and she's going to give the presentation. So welcome, Laurie.
Okay, well, thank you. Welcome to all of you who are on the chat line. I have never done a webinar before, so I'm kind of going back and forth and figuring out where I'm supposed to look right now. And so I'm going to kind of watch that chat box, because any kind of questions you have, please feel free to go ahead and put those up there as I go through the presentation. I'm looking on the left-hand side of the screen and see that we've got about 10 participants on the group right now, and some of you I know I already know. I see Spring Branch Health Clinic on there also. So to all of you, welcome for being here today. I hope that this is something that is helpful to y'all. As you know, right now we're in the middle of our legislative session, and women's health is certainly one of the big issues. So I hope that as we go through the presentation that we can come up with ideas that will be helpful as we move through this session. And then, of course, way beyond too, like in terms of women's health. Our Women's Health Initiative will certainly go on, as we say, 365 days a year. So, okay, so we're going to get started. Y'all bear with me. Like I said, I've never done one where I'm not looking at the audience, so I'm not quite sure how this is going to go. But I wanted to start by giving y'all just some information on, oh, there we go, thank you. I've got to learn how to push buttons. I wanted to start by giving y'all some information on One Voice Texas. You know, we talk about now in terms of advocacy, how important it is for all of us to be working together, that we can no longer affect change if we're working in silos. And so what does it mean to be working together? What is a collaborative? And of course, there are many, many different levels of collaboratives, but I think there are just some basics that as we work through the collaborative process and through collaborative models, that we need to keep in mind some of the basics. And so I'm going to use One Voice Texas as the example. We are a collaborative. We're also a network working together, and we have a purpose. And that purpose is to address health and human services of our community, all of the health and human services issues. For any of you who have been with us with One Voice for a long time, you know that we got started because of a need to pull our community together under one umbrella to look at health and human services as a component, as an umbrella, as opposed to looking at health and human services in all of its different silos. So that was the purpose for coming together. So the collaborative has purpose, and the purpose is to use public policy initiatives to impact public policy. I think that all of us know that public policy is what makes changes within our programmatic systems. We must have effective and we must have strong public policies if we're going to have programmatic changes. Oh, okay. I gotta get these buttons down. So as we look at One Voice, who is One Voice? Who do we include? Who's in our collaborative? And we look at, we have consumers, we have families. You know, once we begin looking at how do you become an effective advocate, you need to look at who all is impacted. And many times it's not necessarily the folks who we think are the ones who are impacted. And an example of that right now outside of healthcare, but in child and youth services, we're working on some issues around children, youth who are aging out of the foster care system, and have been working for the past year with the banking industry, because we need to make sure that when youth age out of the foster care system, that they have the opportunity to establish banking situations. And many times because of their age, they are not allowed. The industry would not recognize them because they needed co-signers, and they don't have co-signers. So, you know, beginning to look at who are people who maybe non-traditionally we have not played with in terms of advocacy issues. So when you look at One Voice, we're looking at consumers, we're looking at providers, we're looking at boards of directors. Our boards of directors need to understand that advocacy has to be a component of every health and human services organizations. Traditionally, historically, this has not been something that providers, nonprofits have participated in or brought into their organizations at a very high level, and in fact have been in some cases very scared to get into advocacy. But what we recognize now is that I had a man say to me, he was from the national level, say to me, every nonprofit organization needs to have an advocacy committee the same as it has a financial committee. So beginning to understand the role that advocacy plays in the nonprofit. The funding community, it's very important. You know, we have not traditionally brought our funders in for many of our conversations, and yet our funders are very much wanting to be engaged and are engaged in our community efforts now. And of course, then our elected officials, businesses, everything we're doing impacts business. If we don't have education, if we don't have housing, if we don't have health care, if we don't have transportation, then all of that impacts our business industry. And so recognizing that as we create collaboratives, we have to be very cognizant that we have inclusion and that we've brought in all of the community. When One Voice was set up, we recognized that we were coming to the table from many different backgrounds, and that in order for us to be able to accomplish what we wanted to accomplish, we needed to be able to find out where were some intersections and where were some opportunities to work together on issues that were important to all of us. So we very quickly recognized that we needed to create some parameters. And those parameters were put in place in the very beginning and have stayed in place ever since then, which we're now beginning our 10th year. And those parameters were strong prevention and early intervention. We all know the difference that it makes when we can head off problems on the front end, or we can address issues on the front end as opposed to having to wait until we get into crisis situations. And then also maximizing federal funding. We know that in Texas, and Medicaid expansion is an opportunity to talk about how maximizing federal funding, and we'll get into that in a little while. But we know that we leave millions and millions and millions of dollars on the table because we do not bring in federal dollars at the level that we have the opportunity to bring them in. And so how do we create programs? How do we create policy that ensures that we're going to bring in the federal dollars that are due to come into Texas so that we can keep Texas dollars working in Texas? Those were the priorities. As I said, those were the priorities that were established in the very beginning of One Voice Texas, and those are the priorities that have led us down the road since then. So as we look at the focus areas of our collaborative, we're looking at basic needs and community care. When we talk about basic needs, we're talking about housing, we're talking about food, we're talking about transportation, utilities. All of those are important. Those are the basic needs of all people. And how do we make sure that those needs are provided for? When we think about health and human services in terms of, and an example is housing. Housing in terms of vulnerable populations, the chronically mentally ill. How do we make sure that we're utilizing housing efficiently and in a way that brings positive outcomes for people who traditionally have been in very unstable situations? Behavioral health, substance abuse, mental health, children and youth services. We're working on child welfare issues, juvenile justice issues, and then education, and of course today for our discussion, healthcare. But I think one of the things that you can see is that as we begin to lay these focus areas out, what becomes very recognizable is that all of these intersect with each other. We know that if we've got to have basic needs, we've got to have housing for people, and that once we get housing, then we can begin to address healthcare needs or behavioral health needs or food needs or education needs. And so really we're just looking at a circle of people. So why are we effective? We're effective because we have over 100 organizations that are members of One Voice, and we're leveraging the expertise of all of those. And what I mean by that, and I always give the example, this was several sessions ago, several legislative sessions ago, but we have someone who, his background is healthcare. and he was in the Capitol most of the time during the legislative session and was very well known for his expertise in health care. But he also represented one voice down there for many of our issues, and one of them happened to be utilities. So all of a sudden we had Randall testifying on the need for utilization of the Texas System Benefit Fund for electrical funding for people vulnerable populations. So all of a sudden, a man who was very well known for his health care expertise is giving testimony around the need for subsidized utility. That's a health care issue. So it's beginning to look at how do we blend and braid all of these different entities. So it's bringing these like-minded coalitions and stakeholders together. So all of a sudden, a healthcare person is saying through a consistent message, we need to make sure that we're utilizing the Texas System Benefit Fund for what it was intended, which was to serve vulnerable populations in their utility bills. And why we're effective is that we recognize Health and Human Services as that total system, that people's ability to have utility service impacts their health care standards and their ability to take care of themselves. So when we look at advocacy in Texas, it's very important that we understand Texas as a state, and in terms of how it utilizes its revenues and how it spends its revenues. What does it support?
All callers are muted and they can unmute themselves.
Okay, thank you. So we want to look at the state of Texas in terms of who we are. And we are a state with low taxes and limited government. Now, people say that's fine. We don't want to pay high taxes, and that's certainly one half of the equation. What that means in terms of Health and Human Services many times, though, is that we have a very weak safety net. We don't have the revenue in place to support our Health and Human Services industry. So where does our revenue come from? Our revenue, as y'all know, primarily comes from sales taxes. Well, in Texas right now, we are increasing our sales of services and not necessarily products. So things that enable the state to raise revenue are not the things that we see increasing, but instead we see things increasing. And I always give the example of like when we go get our nails done, or when we get our hair done, or when we have the plumber come out. Those things are not taxable. So as the state is looking at becoming an industry more around services, then how do we begin to raise revenue? So there's one of the weaknesses. When we look at our budget in Texas, 25% of our general revenue, that's just state dollars, 25% of our state dollars currently go into Health and Human Services. And Health and Human Services are like the five big agencies in Texas: Health and Human Services, DADS, DARS, DISHES, DFPS. So 25% of general revenue goes into Health and Human Services. But out of that 25%, 85% is spent for Medicaid. That's the fastest growing, and I know y'all have heard this many times over, that's the fastest growing expenditure that we have on the books. And that's not exclusive to Texas. We see that across the nation in terms of programs like Medicaid. Right now we have a Medicaid program that we get about 60 cents on the dollar back from the federal government. We put about 40 cents into it. So 85% of that 25% budget is going to Medicaid. Right now, our current budget, the budget that we're in right now, when that budget was written, it did not recognize population growth or increased cost or utilization. So when agencies wrote their budgets for the last legislative session, they had to write their budgets based on no growth. Well, we know that that's just not the way Texas is moving. And so we knew when those budgets were passed that we had under budgeted. And an example of that is Medicaid. we knew when the session closed last time that we had not funded Medicaid appropriately and that we would be at least $4 billion in the hole when the session opened in January of 2013, which is what happened. And then the legislature very quickly appropriated $4 billion in general revenue to make sure that we had enough money to keep the Medicaid program working. We also have very low reimbursement rates, so it's very difficult in our state for us to build capacity. We have workforce shortage issues, but even where we see that we have providers in place, it's very hard to increase that provider level just because of the reimbursement rates. So what are some of our challenges? We have 1,000 new people every day moving into Texas. That's a huge population growth. And so what does that mean? When we're writing budgets that say we're not going to have any growth at all, and the reality is we have 1,000 new people a day coming in. Many of those who are vulnerable populations, lower income populations who very much are going to need public help. We're the second in the nation with an underage 18 population. That's very significant. What does that mean in terms of education, in terms of graduation from high school, in terms of college graduation, in terms of parenting, in terms of workforce? What does that underage 18? It's very impactful. We're near the bottom of the nation in per capita spending. If we look at our population as a whole and we look at just general revenue from Texas and we compare it against all the other states, Texas spends about half of whatever other states in the nation spend per person. Now that's not just health and human services, that's everything. That's the roads, that's education, that's anything that's in the state budget, but we're still near the bottom. So what does that mean? It means we have a lot of potholes in the roads. It means we don't have good education. We don't have good health and human services, strong systems. So we're going to be in the bottom in a lot of levels. We're in the bottom 20% within the nation in terms of the health of our citizens. And y'all being in healthcare, you know all of this, that we have high rates of obesity, diabetes, cancer, all of those kinds of things. 86%, and this is very important as we begin to look at the change in healthcare in our nation. 86% of Texas businesses employ less than 100 people. And what that translates to is that you have a huge population that's uninsured. And so as we begin to look at the Affordable Care Act and we begin to look at models that recognize not only Medicaid expansion, but also the healthcare exchanges, we've got to keep in mind that we have millions of people, hundreds of thousands for sure, that are going to be impacted by these changes, because right now we have a very high population of uninsured people. 62% of small business owners nationwide do not provide health coverage. And I just got the statistic yesterday that in Texas, only 49% of people are covered under employer-sponsored health insurance. So we have 50% of our population. And we need to keep in mind that when you're looking at a high percentage of Texas businesses employing less than 100 people, those are not necessarily high-paying industries. And so you have many people who are working at minimum wage or somewhere just above that, and the ability for them to go out and get insurance coverage on their own is just not, it's not affordable, that it can't be done. And because of the way our Medicaid is structured, we truly have a Medicaid system that's structured as a disability program, not as a healthcare program. So when we look at healthcare across the nation, what are some of our program challenges that we have? We have the highest per capita health spending of all industrialized nations, $8,200 in all funds per person in this nation. And yet we probably have some of the worst outcomes of anyone in the world. and we have the highest percentage of gross domestic product spending in terms of health care. In all other industrialized countries, costs are low and citizens are guaranteed access. And that's what we're trying to look at now when we talk about the Affordable Care Act and expansion of programs such as Medicaid and building in the exchanges in the different states. So in Texas, 1 in 4 of every person is uninsured. That's the highest in the nation. 25% of Texans are uninsured right now. The national average is about 17%. And 1 in every 3 Texas women is uninsured. You know, when you even look at Medicaid, the way our Medicaid program is structured now, while a woman may be able to be on Medicaid during her pregnancy, she's not able to be on it other than that. And so once again, very, very limited in terms of the ability for people to be insured. We have 1 million women aged 22 to 44 who need publicly supported preventive care and birth control. And the way that, once again, we have our public health, our public system set up, we do not have access for those women. We rank number 1 in the percentage of women who've not seen a doctor in the past year due to cost. When you go back and you look at reports, what women are reporting is, I had to buy food for my children, I couldn't take off of work, I had to pay the rent. So it's not, they're not aware of the need to see a doctor. It's prioritizing when you're living on a limited budget. And then, as I said earlier, our Texas Medicaid program is strictly a disability program. You have to be, for any of you who know Medicaid, and most of y'all do because you're in healthcare, you know that if you're going to be eligible for Medicaid, you have to have already passed the critically ill point. And so having the ability to utilize healthcare in the early stages through our public systems in Texas is just not happening. So let's look at women's health care. Let's kind of see, where have we come in terms of women's health care and where are we now? If we look at women's health care in terms of how it was created in our state, we can see that truly women's health care was a bipartisan issue. If you look back in the late 1960s, you'll see that then Congressman George H.W. Bush was the person who really championed public health care in terms of family planning and said, if family planning is anything, it's a public health matter. So this goes all the way back to the 1960s. In 1970, we had a federal act that was signed by President Nixon that established the Title X Family Planning Program. In 2007, we rolled out the Women's Health Program. This was meant to provide preventive care and family planning services. This was rolled out by Governor Perry in 2007. At some point, and not just necessarily in Texas, but at some point, women's health has truly become a very politicized issue. And we can see that in 2011, before the last legislative session opened, the Legislative Budget Board, when it did its calculations on the budget and in terms of revenue and expenses, it stated that it would like to see the women's health program continued, because it saw that we were going to be able to save, based on the trends, we were going to be able to save almost $4 billion in pregnancy-related Medicaid costs. We all know that pregnancy, I think a Medicaid pregnancy is around $11,000 versus about $150 for preventive care. So the LBB itself recommended this is a good program, it shows positive outcomes, and it brings cost efficiencies. This is a program that needs to be continued. But in spite of that, the Texas legislature, as y'all know, cut the funds for family planning from $111 million to $38 million. Now, this was a cut that occurred in the federal dollars, the federal programs, Titles 5, 10, and 20. And what that meant in Texas, those programs have the match, the general revenue match. And so what Texas said was, we're not going to put the match in anymore, that we need to use that money for other things. And so when Texas cut its match, then that cut what came into the state in terms of the federal federal dollars. At the same time, Texas also said they went back in and they reauthorized exclusion of organizations affiliated with abortion providers that were providing services in the women's health program. This was an exclusion that had been on the books for years, but had not been adhered to because Texas recognized that probably it was discriminatory, and so they just never basically pulled the trigger on it. But they did this last in 2011, and that was one of the reasons that then we began to see so many clinics close, not only our Planned Parenthood clinics, but clinics that were recipients of those federal dollars. And since they were not going to be able to receive those federal dollars anymore, those clinics were closing. So we've seen at least 53 clinics closed. We've seen 147,000 women lose access to preventive care. But I think the most important thing that we've got to keep in mind is that we've seen the dismantling of a safety net. And for all of y'all who are in the healthcare industry, you have a very clear understanding of how difficult and how long it takes to build a program. And that once those programs become dismantled, you can't just go back in to the legislature and say, okay, let's put some more money in and we'll get these things back online again. It just doesn't happen like that. And so as we dismantle this safety net, we are going to see ourselves in critical need of care for years and years to come. This is not something that can be rebuilt overnight. So right now, as we're looking at our current healthcare opportunities, we know the situation. We know that women's health care has been cut. We know that women's health care is under fire right now. We know that there's a lot of politicization going on. But if we want to look at how do we strengthen, how do we bring back access, service delivery in the women's health care system, what are some of the options, what are some of the opportunities that we have? And we need to first look at the Affordable Care Act. The Affordable Care Act, as y'all know, is it's the federal health care reform. It was upheld by the Supreme Court last year. You know, there have been people who said, well, we're not going to do this, we're going to get out of this. Well, it's the law of the land now. The Supreme Court upheld it. It is here to stay. And so what we need to do now is look at, all right, what comes in as a result of the Affordable Care Act? And so the Affordable Care Act establishes a lot of requirements. It puts in a lot of changes in terms of how insurance is afforded to people and what is underneath insurance coverage now. So it has what are called essential health benefits. And some of those essential health benefits are very beneficial to women's health. If you look at, there's a whole list of the essential health benefits that have to be provided in every state. Then, and those essential benefits are benefits that cover, they're services that cover everyone. But then there are an additional, I think it's 22 services that are in the essential health benefits that are strictly for women. So things like anemia, cervical cancer, and those are provisions within the essential health benefits that under coverage must be recognized and services must be delivered for those. So as we look at women's health care, starting in August of 2012, there is no longer a copay for certain services. One of those is a well woman visit. Another is DNA testing for cervical cancer. There's a whole list of them. So those are services that under ACA, the ACA is recognizing as preventive services that if we can find those, if we can diagnose those early on, then in terms of the healthcare industry as a whole, we have the ability to save those dollars that become so expensive if we don't diagnose cancer early or if we don't provide family planning early. So there are a whole list of those services. The Affordable Care Act also talks about premium increases, how much premiums can or cannot go up. It talks about pre-existing conditions. You can't limit health care coverage now because someone's had a pre-existing condition. You can't also put caps on maximum coverage. So an example that someone gave yesterday was, if you look at Christopher Reeves, the man who became paralyzed, his insurance at the time of his death was about to max out. Well, now that insurance can't max out for things like that. So also the Affordable Care Act creates health insurance exchanges, and that's a whole discussion in itself. But what the exchanges do, and we're going to in Texas, because we didn't choose to do a statewide exchange, we're going to be part of the federal national exchange. And what the exchanges do is enable people who are above the 133% level. 133% and below will be eligible for Medicaid. 133% to 400 will be eligible in the exchanges for some subsidy insurance. So you can have your insurance, but if you're in these certain income brackets, the federal government will kick in a subsidy to help make sure that you're able to pay that premium. Then anybody at 400% and above, you're certainly going to be able to be part of the exchanges. You just pay your own health insurance. So people who right now may be self-employed may want to take advantage of the exchanges. So that's going to be a whole industry in itself. Then right now, of course, the big discussion is around Medicaid expansion, Medicaid transformation. As y'all know, in the state of Texas, leadership has stated that no, they do not want to do the exchange. Well, and you also know that there were many other states that several months ago were saying no, they didn't want to do the exchange either. But when they began to look at what it meant for their states economically, most of them, or many of them, are saying now we can't afford not to do the exchanges. I'm sorry, not to do the expansion, the Medicaid expansion. And so that's something that Texas is still continuing to look at. Under the Medicaid transformation, what we're going to see is that new populations are eligible for coverage. One thing I want to state up front, there have been some conversations around the ability for like counties to do their own Medicaid expansion as opposed to the state. Well, you know, if the governor doesn't want to do it, what if our Harris County says, well, we'll just do it ourselves? Well, the Center for Medicaid and Medicare Services has already said, no, you can't do that. You come in as a state. So that discussion is no longer viable. But under Medicaid transformation, we're going to have many new populations that are able to come in. We look at parents of eligible children. Right now, parents do not have a place to go in terms of public health insurance. This would open up the door to them. It would open up the door to single adults. So people who do not have children but need health insurance coverage and fall under the 133% poverty level would be able to obtain Medicaid coverage. And seniors and persons with disabilities. This is a huge change in Medicaid because it does open up the door, and I don't remember what the numbers are right now in terms of how many people will be eligible under this new definition of eligibility for Medicaid. Also, Medicaid will pay, persons are eligible up to 133% of the federal poverty level, which is about $30,000 for a family of 4. Where the states are struggling is under this 100% federal funding. Right now, between 2014 and 2016, the federal government will pay 100% of Medicaid cost if a state agrees to go into the transformation system. For Texas, over the next 10 years, not just the 2 years, because at the end of 2016, then each state begins to kick in a percentage in match. But that percentage will never get above 10%. So right now we're paying 40%. Under transformation, the state would pay 10%. And depending on how you do the calculations, kind of determines, right now the figures are anywhere between about $6 billion and $15 billion in terms of what the state of Texas would put in as its match. But the state of Texas in the next 10 years has the opportunity to bring in $120 billion in federal funds for Medicaid expansion. And what we've got to think about is that not only does this $120 billion cover direct care, so medication, the service delivery system, seeing the doctors, all those kinds of things, there will be dollars in here that will enable providers to begin workforce development. Because what you're going to see here is, if all of this rolls out correctly, the way people are looking at it is that the dollars will be available within the system for organizations to also increase capacity. And that's the struggle, because when you start talking about workforce development, you're talking about economic development throughout the state. And so businesses are saying, okay, wait a minute. You know, let's think about what this means for our state and for our business sector. So right now and one of the things people need to understand too is that, you know, there's that discussion, well, the $120 billion, if we don't take it, we just need our taxes reduced. No, the money's already in the federal system. So it's already been allocated, it's already been appropriated to Texas. If Texas chooses not to go into the new Medicaid system, those dollars, $120 billion, will simply be transferred to another state that is choosing to go into it. So our federal tax dollars that you pay every year in your federal taxes will all of a sudden go to New Jersey or Arizona or another state. So it's not going to mean Texas gets some kind of relief in terms of the federal taxes that you pay. So that's one option. And I think one of the things you can see is that, whoops, can I go back here?
Trying to go back
Yeah,
to the
just,
previous slide.
Yeah, right. One of the things you can see is that when we talk about Medicaid transformation, we are seeing a population covered that was not covered before. And in many cases, this new population is women. So Medicaid transformation will give women the opportunity for coverage that now is above and beyond what traditionally they may have been able to get in Medicaid. In other words, they will be eligible for ongoing health care in its entirety. It won't be just pregnancy related. They can now do preventive health care. They can do ongoing health care. So that is one of the big things that we need to be looking at when we think about how do we address women's health care needs and public financing. As I said, in the past legislative session, we lost a lot of our funds through the titles program, 5, 10, and 20. So there is discussion right now as to, all right, do we want to restore those funds? And if we restore those funds, we're looking at a minimum of about $56 million in general revenue. One of the things, and then for the Women's Health Program, which is now the Texas Women's Health Program, it would take $30 million plus just in general revenue to replace those federal funds. One of the things we need to be thinking about is, as we look at restoration of these funds and we look at implementation of Medicaid, it's kind of bang for the buck. And it's the eligibility systems, the requirements. We know that there are some eligibility issues within the titles program, like one of the titles program pays for teen care. And so how would we address that in Medicaid expansion? So there's some things there. We know that there's some funds in the titles program that pay for undocumented folks, and we know that Medicaid will not pay for undocumented. We know that there's some differences in terms of the federal poverty levels. So those are all things that have to be addressed. And it's not to say that you do all or you do and then get rid of everything else. It's how do you blend and braid, but how do you also get the best bang for the buck? And so when we look across the board at all of these funding streams, we need to always keep in mind, where are women going to get the best opportunities for coverage? Also, in terms of restoration of funds, we've got to, once again, look at the fact that that provider safety net is being disintegrated. And so even if we restore those funds, do we really have capacity in the communities? And that's one of the things that we're looking at right now through our Women's Health Initiative, is some of the data around that. As many of y'all know, HHSC came out with its capacity report stating that, yes, there was plenty of capacity, and then, of course, they immediately had to take that down off their website because they found out that, no, there really wasn't all that they had out there. So that is still an ongoing issue. That is the presentation. I know we have a little bit of time left. I want to open it up for questions or comments. And
sure, yeah, let me unmute.
Carrie, you'll have to unmute.
Yeah, I didn't do mute earlier.
All callers are muted. All callers are unmuted.
All right, so if anybody has any questions over the phone, feel free to ask, or if you're just online, just type in any questions that you might have. Or are there any questions in the room? We have a few people here in the room as well. Any questions? So I kind of had a question about where the Affordable Care Act is right now. So what's happening with it right now?
Well, right now, a lot of things have already gone into place. We know that parents can keep their young adult children on their policies until they're 26 years of age. There's some pieces that have gone in terms of foster care youth. The piece around copays, some of the preventive care, that no longer will people pay copays for some of that preventive care, that's already gone into effect. So we're already seeing pieces of it in effect right now, and we'll continue to roll out different pieces of it through the, I think it's through the end of next year.
Okay, great. We'll see who else is online. Any other questions from anyone? Martha?
I have just a statement. We at Gateway to Care are hearing that the verbiage for exchange may be changed to marketplace. So if you hear those words, it's the same thing.
Okay, so an exchange or a marketplace. Well, you know, that kind of makes sense because the exchanges are almost like marketplaces. It's where you come to buy your insurance. Yeah, and it's just how you buy that insurance and what's available for you. Yeah, that gives you a lot more options. Anything else? Oh, yes. Okay. Yes. Lynn reminded me. Through One Voice, we have created, it's the Women's Health Initiative of Texas, which is a collaborative that's working on not only the healthcare issues today in terms of the legislative session, but really trying to bring awareness and education about the entirety of women's health care. This is an initiative that will go on after the legislative session. We will be looking at how do we make sure that women's health care is treated on an equal standing and that we have access to women's health care. We have affordability, we have availability for women in our communities. You can contact me. I think, let's see, this last slide should show contact information. You can get hold of me and we would be happy to add you to the distribution list for the work that we're doing on the Women's Health Initiative. Anything else?
Just also say that as that you can be very much involved. The other day, one of the issues we're going to go for Advocacy Day, Breast Health Advocacy Day on Tuesday,
And, you know, it's so easy to pick up the phone and call your representative. And so I did that the other day and really shared, you know, there's a couple of things that we're addressing. One in particular is the Cancer Prevention Research Institute of Texas. They really don't want to fund that program right at this moment, but it has really been essential for screenings in the community, but also the research, you know, really has made some strides in research. So, you know, when you get really passionate, or if you, you know, pick up that phone and talk to your representative, they have people that are answering, you know, listening to your concerns and gathering all that information, and you do have a voice in making a difference.
Yes.
So,
yeah, and you know, also keep in mind that all of your legislators have emails in their offices, and that there is a database system within the legislation that tracks all of those emails that come in. So send emails to your legislators. Let them know when there are critical votes. We usually send out alerts. So let legislators know how you want something voted on, because all of that gets tracked.
Margaret,
Right.
Can you see Margaret?
Sure. I'll read it out loud. Dr. Nosek has a question or a statement. I'm concerned about the prominent role of insurance companies in the ACA. They stand to be the only winners as they continue to make huge profits off the new mandates. The people I work with don't have the money to buy insurance even through the exchanges.
You know, that will be an issue. I mean, that is an issue. I think that's one of the reasons that, number one, we want to make sure that we get Medicaid, because that will ensure that we can expand the population of those folks who cannot pay for health care. It is one of the ongoing discussions right now in terms of the exchange and the affordability. While there will be subsidies available within the exchanges, I mean, you're right. Many people are living paycheck to paycheck and can't afford to put funding into insurance. So that is one of the issues. You know, another issue that's being talked about right now is the fact that copays, and those copays, depending on the coverage and all that kind of thing. You know, one of the things that's being talked about is the idea that copays can be very, very limited. It may be something like $1 or $2, and there may be a cap on the maximum copay that a family would make, depending on their income. But then again, you get into that discussion about, well, I certainly understand that, and the skin in the game and personal responsibility and all of that, but you still have people out there who just flat don't have cash. And so what does that mean in terms of health coverage? So you're right. I mean, these are all issues that are still very much talked about. And there is no resolution right now.
So even with the ACA, do you feel that, I know it's a kind of the concern of a lot of nonprofits that provide safety net care, like screenings and that kind of thing, like, will we disappear because of the ACA? So do you feel that there is always going to be that need, because there will always be people without health insurance even when the ACA is in full effect?
Oh yeah, I mean, even, you know, when you do the numbers right now, there's still a population out there that's not going to have coverage. And you know, one of the components of the ACA are fines, that people will pay a fine if they don't have health coverage. And there are a lot of people, when you go look at the fines in terms of the amounts, there are a lot of people who say, I'll just pay the fine. So, you know, yeah, there will always be a percentage of people who do not have health insurance. There will always be the need for the safety net. You know, even if we do Medicaid transformation, you're still going to that's a safety net in many cases. That's still going to be a safety net population in terms of the provider capacity and all. So yeah.
I think that's important for funders to know as
Yes.
well.
Yes.
If they
Yes.
stop funding screening programs,
Right.
there's still going to be people who need those programs.
Exactly.
And part of that safety net is just getting people to understand how to use their resources
Yes.
and how to sign up for those resources.
Yes.
Because it's complicated.
Yes. Yeah, and that is one of the things, I think that as a community we're going to start looking at is how do we make sure that we are getting the word out and that we're putting in place the mechanisms to get people signed up. I know a lot of y'all through your clinics or your organizations, you have application eligibility.